Our CVent host is going to allow people into our room, please. Kamal, would you please allow people into the room? I am unable to hear you if you're in the background. Kamal, I would ask that you would please. Ayana, can you please push out a message to the whole conference to come to this session right now? Maybe people don't see it.
This is a live stream, and so folks will be in the attendee hub. We won't see them in the Zoom room.
Thank you. So are people in this space now? Has it been opened? Welcome, everyone. My name is Dr. Eliana Ramirez. I am the CARE TA Center Project Director. It is so nice to be here with all of you. Thank you for coming back. For those of you who were with us during our welcome session, for those of you who are just logging in now, you have joined us at our Fireside chat with 3 leading experts in the field of behavioral health and crisis care, anti-racism, and LGBTQ affirming care. We are so very fortunate to have Mary Rory, who is an expert from a national level. We have Kelechi Uboso, who is a peer who is featured in several phenomenal works and has done work in California, but also across the nation. And we also have Mandy Taylor, who is doing very exciting work in LGBTQ care across the state of California. As I shared in the last session, we are striving to be trauma informed, which means that we feel it to heal it. And so I'm just acknowledging that there was a little bit of a tech moment just now that I am recovering from, and I imagine some of our presenters might also be recovering from, and some of you in the audience might also be recovering from. But briefly, the purpose of the Fireside Chat is that in 2020 and 2021, we have experienced so much isolation and so many, gosh darn, Zoom meetings that it can be exhausting to sit and receive information via Zoom. So we created Fireside Chats at the beginning of both days of this conference to create more of a conversation, to create more of a sense of people communicating with each other. So today's Fireside Chat is about anti-racism and the crisis continuum of care. And I'm going to invite in a moment Mary to speak, Dr. Rory. It is such a deep honor to have you here, ma'am. Your work on a federal level is of the legends, and it means so much to us that you would make time to be here to speak. I know that you are a often sought after speaker. So with that, I will invite Dr. Rory to please share her brief presentation. Then, as I mentioned, we will go to Ms. Kelechi Uboso and then to Ms. Mandy Taylor. Mary, please speak.
Thank you so much for having me. And I want to thank our distinguished panels. And I dare anybody to leave before they hear all of the panelists. That's my call. All right. I'm going to take a different twist, but I hope to answer the questions. Bear with me. Do you think substance use disparities exist in behavioral health care? Yes, it does. What I hope to convince you very quickly is that our job, I'm the director of the Office of Behavioral Health Equity for SAMHSA, is to be brokers of behavioral health disparities, information, and prevention. So before we can begin to think about hiring practices and addressing crisis, how about we prevent it in the first place? Prevention is key to good public health and maintenance. Best practices to reach underserved or disparate populations are to go where they are, approach them in a culturally relevant, sensitive, and empathetic manner, because without behavioral health, there is no health. In order to prevent trauma, crisis, substance use, mental illnesses, we must prevent it in the first place. But if we fail, there is always treatment, recovery, and relapse, which should be available over the lifespan. In other words, culturally target your target population. Then together, we will get there together. Now, let's see if we can answer some of these tough questions. So, what are the most important practices and policies? Forget about the policies and practices. Come to work with heart. If you love yourself and you love your family, you'll love everybody else. Come to work with heart. You put your heart on the front sleeve of anything that you do each day, it will come through. That way you won't offend anybody. That way no one think about racism or discrimination. Think gold standard for everyone. So that's my advice there. Business practices that I would recommend to retain, hire the right folks, the diverse folks. What you want to do is reach people where they are. Let them lead. Trust them. At my office, I am the director, but everybody that works with me are co-directors, right? And when they say with their level of expertise and passion that something is, then it is. Do not question, support. But on the other hand, if they fail to deliver something, that's not bad news. That's called a lesson learned. You simply say, well, we were not supposed to do it that way, but we did. We apologize. And we don't get stuck on stupid. We move on to focus on the problem at hand, the target population at hand that desperately needs our support and help to be on the right track. So let the folks lead. You hired them, you interviewed them. Let them lead once they get there. Give them bonuses when you can. And when there's no money, let them lead on a publication. When there's no publication to lead, then simply give them some time off, a way to step away from the job. If there's no opportunity to do that, create a research day. This is 4 hours a week that you give your entire team to just do what they need to do. Is it researching? Is it catching up on work? Is it taking care of their kids? 4 hours. There's no meetings, there's no calls, there's no nothing. Allow them the time to be the best in their field by giving them the time. Now, how do you attract them in the first place? Well, we need to diversify the world. We are no longer black and white. We're everything, right? There are over 700 minority serving institutions across the country. Hint, hint. Within those institutions, we can advocate that it is very sexy and appealing to go into behavioral health. Everyone has someone in their family that has gone through some type of crisis, some type of trauma. We've all lost loved ones. So it's an everyday occurrence. Why not? Right? Why not? I know you want to be a runway model. No. I know you want to be a football star. No, I know you want to be. No. Go into behavioral health, become that psychologist, become that interventionist, become that counselor, become that social worker. This is my plea. I'm sorry, it's a shameless plea, but this is where we start. We start there. And if I can push the envelope a little further, let's go even lower. When we go to have, career day at our educational institutions, why can't we show up in kindergarten? Why can't we show up in first grade? From there, we can show up every year from first grade, pre-K, all the way up through 12th grade. You should become a social worker. You should become a psychiatrist. We can do this, but we have to strategically think and plan how we'll get there. Finally, what else? Let's see what else I can answer before I pass the baton on. I want you all to think about no racism. I see we're supposed to be focusing on anti-racism. There is no racism. There is no discrimination. Think about a world with no color, no LGBTQ. Think about people with a beating heart. That's all you have to do. Position yourself there to think every day that I get up, I'm serving someone to improve their overall quality of life from birth to death. Think that. That's all you have to think about. in order to continue to do the great work that you do. Thank you so much.
Thank you, Dr. Rory. I imagine thinking about speaking to preschoolers and kindergartners, encouraging them to go into social work. And I think about especially how important that is for our children and youth of color. To hear that they can grow up and make major contributions in the world is a beautiful, powerful piece. Thank you so much for that, Dr. Rory. Now we're going to go over to Kelechi Uboso. It is such an honor to have Kelechi present. The questions that the panelists, as Dr. Rory shared, have been asked to describe or to respond to. The first is, please describe your experience providing, designing, researching, and or accessing crisis care. Has your experience been impacted by race, ethnicity? If so, how? The second question, what are the most important policies and practices crisis care providers and systems can implement to best serve Black, Indigenous, and other people of color? Thirdly, what business practices would you recommend to promote effective recruitment, hiring, and promotion of a diverse crisis care workforce? And finally, if time permits, what advice do you have for the audience to maximize their learning at a conference about anti-racism? And part of the beauty of being in a diverse community is that we are also coming with multiple opinions and perspectives, and we welcome all of that in this space. And so with that, thank you again, Dr. Rory. And now we will go to Ms. Kelechi Uboso, please.
Thank you so much, Eliana, and good morning, everyone, or good afternoon. I'm really grateful to be in this space with you all. So I might be taking a little bit of a different turn, but all good here. So I'm Kelechi, and I'm interested in BIPOC healing and liberation, peer support, research, and suicide prevention. I am a writer, advocate, suicide attempt survivor. And when we think about accessing crisis care, I really want to share from a lens as a Black woman and from a structural lens from my research and community engagement work. And I want to leave you with a very long set of questions to reflect upon as you move through this conference and beyond. And don't worry, I can also email you the questions. So as the co-editor of We've Been Two Patients, Stories and Voices Challenging the Biomedical Model, I believe in the power of storytelling. So I want to share a little bit of that because it is a tenet of the consumer movement and critical race theory. So when I was 13 years old, I was a Black goth kid growing up in the segregated South, and I felt out of place everywhere. Because of redlining and structural racism, I split my time between a predominantly white private school and an all Black neighborhood. No place was home except for with grandma. She accepted me, she showered me with kisses, she believed every meal should have a dessert. And when she died, my world halted. It wasn't only her death, it was rejection from my community, racism at school, and insecurity with boys. I struggled with suicidal ideation and I attempted. And at 13, I ended up in a psychiatric hospital, and it was really, really scary. I was treated like I had done something bad, like I was in trouble. Teddy bear confiscated, shoelaces gone, sleeping in a hallway with strangers on a cot with bright fluorescent lights for suicide watch. And I think the most harmful thing was the staff told me I was broken. I would always struggle to have a job or relationship. I had a chemical imbalance, a brain disorder, and that I would always suffer and need medication. I didn't know this was true. What I wish happened was that someone had showed me coping skills for dealing with losing a loved one, navigating isolation and racism. I wish someone had asked me what a world might look like that would feel livable to me. No one did. I started pretending everything was okay because I didn't want the future life trajectory I was given. And looking back, I know the crisis treatment I received was nearly as traumatic as the suicide attempt itself. And we really have to take the trauma out of treatment. So let's fast forward to my 20s, living and working in New York in 2008, the thoughts returned, and I decided I really want to stay. And this is where I want you to all think about the impact that racism has. I was turned down by therapists left and right the minute I said suicide. And even though I carried a lot of fear from my previous psychiatric hospitalization, I was running out of options. I had never heard about the peer movement. I didn't know about peer support or peer respite centers. So I went back to the psychiatric hospital, but they didn't believe me. Because I was able to articulate that I needed help, They labeled me as high functioning. They couldn't see I was struggling because they didn't see my challenges. And I always consider the role racism plays when a Black or BIPOC person tries to get help. We may present differently, which means we may be interpreted as aggressive or numb or stoic or angry. Or in my case, oh, you're fine. You're so articulate. You don't need anything. They released me immediately, and I attempted 3 days later. I tell you this not to activate you, but to say that racism doesn't always look like we think. It can be subtle, not by the people who feel it, but it doesn't always look like racial slurs. It can be not believing someone when they say they need help, or perceiving someone isn't in pain when they are. And I want to underscore that the belief that Black people feel less pain has dated back to slavery and still persists today. And enslaved people were described as being immune to mental illness because they didn't have property, engage in commerce, or vote. And so this immunity hypothesis and having thick skin have unfortunately become adopted cultural beliefs in the Black community. It is unlikely that many know the true origins of these ideas are rooted in structural and scientific racism. I didn't know. And it is no accident that Black families ripped apart by slavery and carceral systems would double down on narratives of being strong or getting over it or keeping family secrets as a protective measure. And I believe this may resonate with many other racial identities. So when I was admitted for the attempt, there was no peer support, there was no wellness recovery action planning, there were a lot of movies and coloring, locked doors, bulletproof windows. Ask yourself, does this sound like a place of healing? It was not a peer respite, a voluntary community-based trauma-informed person-centered crisis support, right? Run by people with lived experiences. So I just want to uplift a little bit of my story. Eliana mentioned this in the opening, but this year I embarked on a qualitative research project called Black This Whole Time, the Black Lives Matter era and the urgency for Black liberation within the Mad Pride movement. I talked to Black activists, psychiatric survivors, healers, organizers, and I learned so much about what we need and how Black voices have been erased, oppressed, and silenced in all movement spaces. So they said, listen. Yes, listen is what they said. I also had to go deeper to understand scientific racism. So this year, the American Psychiatric Association apologized, like many institutions, to Black, Indigenous people of color for its support of structural racism in psychiatry, right? They finally admitted to subjecting folks of African descent and Indigenous people to abusive treatment and racialized theories. And so, for example, drapetomania was a mental illness label given to enslaved people who ran away. Take a minute to think about that. People who ran away from slavery were diagnosed with a mental illness. So we have to look at the roots of structural racism in our diagnostic criteria, like in 1960s when the DSM was updated to add aggression and hostility as signs of schizophrenia as a trend to overdiagnose and overmedicate Black people because of their civil rights belief. So that's a lot. When I think about structural racism in our crisis system, I'm reminded of a project I did with a California county and their psychiatric emergency service unit. When our team disaggregated the data for race, we saw a disturbing trend. Their Black and Latinx community were overwhelmingly diverted to jail mental health during a mental health crisis, while the rest of their community were sent to the mental health system. It is very important that we disaggregate our data by race to tell the complete story. For example, I know folks in the suicide prevention world were very concerned during the first wave of COVID that suicide deaths would rise. And then I started hearing the great news that the rates were down. But Johns Hopkins researchers nuanced the findings and said that actually suicide deaths doubled in Black Marylanders and halved in white Marylanders. So whose narrative is being shared and what stories are being uplifted? When I worked on a digital mental health literacy project and spoke to community members from Modoc County all the way up to the top of our state to LA, we heard so many different things about what people needed for their mental health. And the most common answer, what people wanted across older adults, young adults, trans women, everyone, was social connectivity. When we asked peers what they needed or they hoped technology could support them with, we heard that peers wanted 24/7 peer crisis support without law enforcement or forced treatment. And so I have to have the conversation that a lot of us don't love having, but for too many people, a mental health incident results in criminalization, persecution, or death by police. And we found the 2015 report by the Retterman family shows that 50% of individuals killed by police in the US had disabilities, and a large percentage of those folks had mental health conditions. So as you start to see legislation like AB 988, which we really were excited about, which was going to implement a system for people experiencing mental health crisis, would have an alternative to 911 and staffed by mental health professionals and trained peer supports, and can be an alternative to police. When you see something like that get stripped down to being just a 3-digit number for a crisis hotline, we have to say, like, we have a lot of work to do. And one of the biggest barriers we run into when we're serving our BIPOC folks is the issue of fear and liability. It is an issue when people prioritize liability over our health. So I want to uplift that the Trans Lifeline does not engage in non-consensual active rescue. And since their founding, they have divested from the police. How did this happen? Well, they are trans-led and they center the safety and experiences of trans people. What can we learn from that demonstration of love? So I've said a lot, and I want to leave us with some things to think about and maybe some advice. So as one of the folks that I interviewed in Black This Whole Time, Kwesi Chapman says, we know the nightmare. So what is the dream? Where are we giving ourselves space to radically reimagine our crisis systems? I want you to imagine someone you love. I always think of my mom. And think about the crisis system today. If your loved one was in a crisis, would you take them to your place of work or to the place you refer people when they're in crisis? If the answer is no, and not because of confidentiality, then really think on what would you need to change for you to feel confident that your loved one would be heard, validated, safe, and receive trauma-informed and healing-centered care. That's one place to start. And let's just go ahead and say it. All your policies need to change and be revisited with an anti-racist lens. How are you authentically engaging people with lived experience to dream, revise, inform, and build with you? And no, this isn't volunteer work. It should be paid. Also, it's not going to be a one-off focus group or an advisory board. And I have to say, I've seen advisory board used as a strategy to make a controversial issue go gently into that good night. So diversity without inclusion and decision-making, I got to tell you, is tokenism. How have you centered the experience of BIPOC people in your work? How have you been intentional about intersectionality? What is the demographic makeup of your leadership? Is it reflective of the communities you serve? And instead of saying, wow, we can never find BIPOC people to hire, maybe shift and say, why don't BIPOC people want to work here? What are the barriers? Representation, fear of tokenism, your community standing? Oftentimes we can hire a diverse workforce, but not retain them. So what are you learning from the people who have left? Have you asked them if and how racism has played a role in their decision to leave? Do you facilitate exit interviews? And where are you investing in community-based participatory action research, in which you partner with communities as research partners to define and understand an issue? How are you working to understand what crisis means to your community and uplift community-defined evidence? Community has answers. Are you listening? And are you funding these solutions outside of a pilot program? That's a whole nother TED Talk. Are you disaggregating your data by race, gender, sexual orientation? How are you partnering with your community, with folks with lived experience to analyze and understand your data? How are you working with lived experience to implement change? So there's so many questions that I can ask, but we know the nightmare. What is the dream? How can we hold space for what is and also radically reimagine and build something different? And while I personally appreciate and need hope, hope is not a strategy for system transformation. So how will you start to build something different? And the last thing I'll leave you with is, as you move forward with today's anti-racist conference, I want to share some wisdom from Yolo Akili, the founder of Beam. He often says, we've all grown up in a racist, sexist, transphobic, and misogynistic society, and there's a lot that requires unlearning. Yolo encourages us to move away from, is this person racist, to how is racism and other isms showing up in my behavior? This allows some spaciousness to correct the behavior and move away from defensiveness. So in that spirit, I hope there are moments of activation and even some difficulty that you can give yourself some space to unlearn and we can build together. Thank you.
Kelechi, thank you so much. So much of what you said, I'm resonating with and feel like a bobblehead back over here. And I'm sure that our audience as well. Thank you so much. Now we will go to Mandy Taylor, please. And I would like to share with the audience that we are going to go just 10 minutes past the end of this session so that we can make up times to make sure that everyone is able to present. Thank you.
Thanks, Ileana. And thank you, Kelechi. Maybe we could all just take a breath, because that was pretty powerful. Maybe just take in what Kelechi just shared with us. Yeah. I'm gonna actually start with the last question. That's our optional question of what advice do I have for the audience to maximize your learning at a conference on anti-racism. And there's a Buddhist saying that's strong back, soft front, that you might hear things during this conference that are different than your own experience. And so I would just encourage folks that maybe if you are a white person or you are a straight person or a cisgender person, if you are a man or an able-bodied person and you are hearing the experiences of folks with different identities than you, and you're challenged by the content, that you really just mindfully acknowledge that dissonance that you might be feeling, and stay present with the conversation that's happening, and really take a moment. I know that sometimes defensiveness might be our first, like, well, that's not how my org is, or that's not how I do it. And so we just want to, strong back, soft front, hold the framework of who you are as a professional and as an individual, your kindness and your integrity and your curiosity, while you open yourself up to receive this new information. So I want to start with that. And our first question was to describe our experience providing, designing, researching, or accessing crisis care and how it was impacted by race or ethnicity. So I started my career in providing survivors of gender-based violence, and in particular, providing advocacy and clinical care for young survivors of sex trafficking, most of whom were involved in the juvenile justice system or the foster care system. And this was actually my first awareness of racism within our system. I noticed when I started going into the juvenile detention center that over 90% of the girls that I was working with were young Black women who were criminalized and put into the prison pipeline for their own trauma, right? They were being assaulted by adults and then they were being criminalized for it. And I remember going, why is nobody talking about this? And the answer wasn't that nobody was talking about it. It was that white people weren't talking about it. And so I didn't know that it was a crisis. And I remember my Black colleagues asking me to speak about it to other folks because they felt like I would be more likely to be heard by my white colleagues. And so that was my first lesson in clinical care, that if you are seeing racism or your colleagues of color are identifying areas for you where racism is existing, and our communities are being harmed, right? These young girls are being harmed and re-traumatized and criminalized, that really, as white folks, what we can do is make sure we're talking to other white folks about what's happening, and educating them. And something else that I learned from that is that the clients that I was working with that were queer or trans, they could often choose to not disclose that they were queer or trans to the folks who were providing care to them. So whether that's in the juvenile justice system or in the foster care system, they could just choose not to disclose to their probation officer or to the detention center or their social worker that they were queer or trans if they were worried and they often were, about receiving negative treatment or negative consequences as a result. Well, you can't choose to be in the closet for the most part about what your race and ethnicity are. They couldn't choose to not experience that oppression. And so just to keep that in mind when we're working with clients. And that also to be aware that there may be some negative consequences if you push back. And I have experienced those negative consequences, and an awareness that the negative consequences that I, as a white cisgender educated woman, experience are pretty damn minimal compared to what another colleague who is a person of color or who is trans would experience. And so that in that way, it's really important that we step forward as allies. And then in terms of experience designing programs, I was the program director at our local LGBT center, and I designed our programs and training and providing crisis care. Like a lot of community-based organizations that are specifically for marginalized communities, we were often the only place that people felt safe. And so oftentimes our community members were coming to us when they were in crisis. They weren't coming towards what would be considered the, the mainstream or the public mental health system. Peer support really is the cornerstone of queer and trans support and community movements. It really wasn't that long ago that being gay was considered a mental illness. It was in the DSM for a very long time. Being trans, they've made some progress in the DSM, but if you are trans and you want access to specific trans-related healthcare, you still have to go to a clinical behavioral health provider and be pathologized in writing via a letter in order to get authorized to get care. So we are still saying we will pathologize you for being trans. So it's really no wonder, right, that our community generally does not feel safe within public mental health systems. And then in terms of how I experienced racism showing up as in a local LGBT center, I frequently heard A-list gays, making misogynistic and racist comments, particularly around things being like too urban, or maybe us needing to have a training around anti-racism practices and supporting communities of color was a bit too much to require of volunteers, right? So things like that where oftentimes my colleagues didn't realize that they were enacting racism. They didn't realize, when they were making comments around trans folks or access to trans care, right? That's trans misogyny and that sexism was showing up. So again, it's really important that folks with privilege that are going to experience less negative repercussions are the ones that are saying, hey, not a cool thing to say, right? And let's have a conversation about why that's not a cool thing to say. And they're just more likely to hear it. Is the unfortunate fact. And just in the same way, right, men should be talking to other men about sexism and misogyny. White people should be talking to other white people about racism and anti-racist practices. Cisgender people should be talking to other cisgender people. We want to make sure that we're not asking our marginalized folks who are already experiencing daily oppression, daily microaggressions, to do that labor without their consent, often is what that looks like, right? So step up and do that. And I want to also just caution us that when we are doing that labor as white people, it is not because we are the savior. It's not because we're the martyr. It's not because we get kudos or cookies or gold stars. It's not because we know best or we're experts on racism. I am not an expert on racism. I have some knowledge that folks have shared with me, and that I am honored to have loved ones and community members who can share their experience. But as a white person, I cannot understand that experience. But what I can do is hear my community members and believe them, believe what their experience is. And act accordingly and in ways that they're telling me feel supportive and feel loving. as a provider or peer. And then in terms of my experience with policy advocacy as the behavioral health equity manager at the California LGBTQ Health and Human Services Network, we did a survey of LGBTQ Californians in 2019, specifically on mental health. We had over 2,800 respondents. And it really showed the same thing that research has been showing, which is QT-POC, so queer and trans people of color, experience simultaneous systemic oppressions, and they are at higher risk for negative mental health outcomes. What we found is that overwhelmingly, QT-POC respondents reported experiencing racism within their LGBTQ communities. All people of color, monoracial and multiracial, identified that as happening, with particularly high rates of experiencing racism if the respondent identified as Black, African American, North African, or Middle Eastern. And then we also asked the question of, what are your experiences with hetero cis sexism in your community of color? And again, the respondents overwhelmingly said, yes, we experience transphobia and homophobia within our communities of color. And so what happens then is we get queer and trans people of color who feel like they cannot get safe and affirming care at an LGBT center, right? Or with an LGBTQ provider because they're going to experience racism. And they also feel like they can't get support through their traditional healing practices or cultural community centers because they're going to experience transphobia and homophobia. And they frequently reported to us that they feel like they have to bifurcate their identities in order to get support. And so it's really important that we acknowledge that. That we acknowledge that these supports are necessary, and just a call out to some of the queer and trans organizations that specifically focus on communities of color are API LA, Gender Justice LA, Trans Latina Coalition, and Rainbow of Truth down on the Luciano Band of Indians in La Jolla. They oftentimes aren't getting funding because they're too niche, right? They want to support the whole umbrella without really acknowledging that within the historical context, white, cisgender, gay men are really often are who being served when we look at the whole umbrella. And so let's really make sure we're focusing and centering our trans communities and our communities of color. We know that violence is committed disproportionately on the bodies of Black trans women. We know that trans Latinas are harmed in immigration detention centers. We know that this trauma has lasting impacts on our individuals and our communities. And so an action that you can take like now is contact the governor, contact your elected official, and tell them that you want to see them put money into the Transgender Equity Fund and get resources to our trans-led community-based organizations that are on the ground. And you can contact the Trans Latina Coalition specifically, who has led this effort with other trans-led organizations, and ask them how you can best support their efforts and amplify their message to get that funded. And then one of my favorite quotes from Audre Lorde really cautions us that we can't fight a single issue fight, because we don't live single issue lives, and that we really need to fight together. We need to uplift and center the voices of those who most need to be heard in that moment. And that can change, right? And so to really think about that in the moments that you're in. And then in terms of important policies and practices for crisis providers, I would say first, on a direct service level, because it can save a life, have a policy with the accompanying training and resources that you never use law enforcement as your first response, right? Because we know that that's how trans folks and that's how folks of color can die, right? That can be lethal. So just have that policy, train your folks on the policy. And you can do that by finding out, is there a community-based mutual aid network in my area? A lot of areas have them. If you're not sure, feel free to reach out. I will be happy to help you try and find one in your area. And then also have a support plan with your community member. And there's this really great one that I love on madqueer.org. It was created and designed by somebody with lived experience in a lot of intersections. And it's called Surviving the Apocalypse Together. And it's a workbook where you can, the person, right, we as community can sit and design plans for how we're going to support each other if we're in crisis. Because I know as a mental health consumer, when I'm in crisis, that's not when I'm making good decisions. And so it's really important that the people around me who love me know the kinds of decisions I would want to make in that moment and support me with that. And then the other thing is, sometimes we don't have control over whether or not law enforcement is called, right? Sometimes well-meaning folks will call law enforcement. So also train your providers that if somebody does call law enforcement, make sure that your white providers know how to put themselves between the client and law enforcement. And that's just to make sure that it's a safe situation, right? The fact is, if law enforcement shows up and I'm supporting a Black trans woman who's experiencing a mental health crisis, I am less likely to experience a lethal or negative outcome, right? So if I can use my white privilege and say, hi, law enforcement, let me tell you what the situation is, right? And let me tell you what we're asking from you. And sometimes what we're asking from you is that you go away, right? But that I have the ability and the safety to do that in a way that my community member might not have, right? So just make sure that your white providers know that, right? Just keep people safe. And then in terms of organizational policies, I'm gonna echo what Kelechi said in terms of listen to your local communities, really listen. Just like your clients know what will serve them best, your marginalized communities know what will serve them best and who will serve them best. Pay for their expertise if you are asking for technical assistance. If you are a funder or a county behavioral health plan or a managed care plan, contract with your BIPOC and LGBTQ led and centered CBOs. If you are a CBO yourself, pay them to train your providers. And we know CBOs, sometimes you don't have a lot of money, right? So if you don't have the ability to pay them, provide some sort of support in kind. So don't just mine their expertise and exploit their labor, right? Ask them, is there something our organization can do to support your organization because we don't have the ability to pay a funder? And sometimes it's something like, hey, would you be willing to partner on having a clinical provider come to our site once a week to support our community members because they don't feel safe going to other locations, right? So there's ways that you can provide mutual aid to each other that doesn't involve exploiting a marginalized community. And then in terms of system policies, ask your experts, your county behavioral health policy experts. Start with your county behavioral health mental health board and your cultural linguistic competency committee. Depending on the size of your county, those may be the same things. If you are BIPOC or LGBTQ, find out how to get on that committee and influence your policies in your county. We need you on those mental health boards. And remember, if it isn't intersectional, it isn't equitable, all right? If you are California, or if you're looking for California behavioral health policy advocates, please make sure that you're looking for the guidance of state organizations who are intentionally supporting queer and trans people of color in their policies. So in particular, REMCO, the Racial and Ethnic Mental Health Disparities Coalition, Stacy Hiramoto there is always intentional to make sure that policies she's putting forward on the state level are also supporting the queer and trans community, queer and trans people of color. The California Pan-Ethnic Health Network, Stephanie Franco, Carolina Valle, and Kieran Savage, always making sure that queer and trans people are included in their policies for people of color. And then my last thing, business practices you would recommend to promote an effective recruitment, hiring, and promotion of diverse crisis care. I would say recruitment is important, and I recommend folks really start with retention. What is your current agency culture? Will your queer and trans and BIPOC providers be so exhausted from microaggressions all day that they burn out? Are they going to get licensed and then leave to serve their community in a more culturally affirming environment? Because that's what I see happening. So I would suggest the radical notion that having culturally affirming services is one of the best ways for you to retain your culturally diverse workforce. Don't make us work in a white supremacist, straight, cis-centered Western medical model, because we will leave and work for organizations that don't do that. So if you want to retain us, that's the best way, is serve our communities, because when you're serving our communities, you're serving us. And that's everything. Thanks.
Oh my gosh, Mandy, thank you. Thank you. Thank you, Kelechi. Thank you, Mary. You know, we've tried out this new platform here, so we're not actually able to see the chat box, but I do want to let you know, our speakers, that Ayana has shared that there's a lot of love in the chat box. People are writing things like, love Mandy's promotion of intersectionality. Another person, snap so hard. Another person, incredibly eloquent message from Kelechi, and other people, awesome, and affirming of what Mandy has also been sharing. So we will definitely get all of these messages to our speakers. I just want to thank all of you for the time that you've put into these really powerful presentations here. I want to also honor the need for our attendees to have some space before the next session. So I would like to invite people who have questions for follow-up. Please do feel free to email us. And we will connect. In fact, if you put in a TA request through our website, we can also reach out to our amazing TA specialists in the field and see if they might have some time available to respond to TA requests, wink, wink, nudge, nudge. The final piece that I'd like to share with everyone is this afternoon in our closing session, we're going to share with you a crisis continuity of care map that's on the CARE website. So you can put in your zip code and immediately see what are those crisis care services that are alternatives to calling 911 in your community. So in addition to 988, that's going to be rolling out in the next several months here. There are also local mobile crisis teams. There are local mobile crisis and, importantly, warm lines as well that you can reach out to, and we'll be sharing those with you. So without further ado, on behalf of everyone, thank you to all of our panelists here today, Fireside Chat, and thank you to the audience.